Good afternoon and welcome to the September 2024 Board of Health meeting. We will get started with roll call.
Jamie Steig.
Present.
Avish Nagpal.
Present.
John Strand. Kayla Nelson.
Present.
Lynn Telford.
Present.
Neemal Day. Bernie.
Present.
Oh. Sounds like she's online. Bernie
Yes, I am.
Dardis. Grant Severson.
Present.
And Jim Capitan.
I am here.
Okay. I would like to welcome public health students. Is that correct? From NDSU? Nursing students, public health? Okay, well, welcome. We're glad to have you. Let's move on to announcements, and I will entertain a motion to approve the agenda.
So
Move
moved.
to approve.
So I got two at the same time, so one of them can count as a second. Okay. All in favor, say aye.
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 Any opposed? Motion carries. Agenda is approved. The minutes from May are attached. So if you've had a chance to review those or not, but I would entertain a motion to approve it.
I'll move to approve the minutes.
Second?
A second.
All in favor, say aye.
Aye.
Any opposed, same sign. Motion carries. Minutes are approved. And we can start with introductions since we have kind of a new setup that I don't really mind. It's nice to be down here. And we've got some new faces as well. So I can start. I'm Lynn Telford, and I am the chair of the Board of Health.
I'm Caitlin Nelson. I'm the Vice Chair of the Board of Health.
Jim Capitan, Cache County Commission.
I'm Larry Anderson. I'm the Director of Health Protection and Promotion at Fargo-Cass Public Health. I oversee our main clinic, our health promotion area, as well as employee health.
Melissa Parola at the Health Department. I'm the accountant.
Jen Fell, the new Public Health Director.
Tracy Newman, pediatrician and health officer of Fargo-Cass Public Health. I'm also an associate professor of practice at NDSU in public health, so I'm excited to see our students here today.
Grant Larson, Director of Environmental Health at Fargo-Cass Public Health.
Hi, I'm Holly Scott. I'm the Public Information Officer at Fargo-Cass Public Health.
Jamie Stagg, board member.
Avish Nagpal, infectious disease physician at Sanford and board member.
Grant Severson, pediatric rheumatologist, board member.
And then we had at least one person online.
Neemal Day, board member and Fargo Board of Education.
Okay, got everybody? Okay. The next item on the agenda is budget recap.
As noted in media and in commission meetings, there have been changes and conversations over the 2025 budget that has been proposed. You have reviewed the 2025 budget that was proposed to you in your May meeting. And when I joined Fargo-Cass Public Health, we moved forward with that presentation of the budget, and there were other considerations to be made to the budget. And the city is continually working through finessing that budget until we get to an approval, hopefully by September 30th. The commission will be meeting as a finance committee on Monday, May 23rd at 10 o'clock in chambers. We have made some changes within Fargo-Cass Public Health, working closely with the management group there for each of them to go back into the departments that they manage and to look at the budgets that they have, the resources that they need to manage those, and them coming forward with changes that they were willing to make as a management group, reviewing those then with the city administrators and proposing that forward to commission. We did have a passage on commission on Monday last week, or actually this week, it's been a long week, that have accepted the reduction in force of 4.2 positions from Fargo-Cass Public Health. I was asked to explain those positions and One of those was a nurse that has a vacant position as of 2 years in the employee health program. Larry, as an RN, has been filling in as a nurse in that program for the past 2 years and continued to feel comfortable in doing so. We had a nurse that was in our nursing program who also was vacant for 13 months, and it had been on the books, did not need to be filled per that director. We had somebody who had moved down to a 0.8 as of April this past year, and we realized that difference of the 0.2 and added that to our budget. We had a recent resignation of a health promotion staff and had decided to not refill that position and have her work spread throughout the staff members who are qualified to do so through the WIC program, stepping in and stepping out of WIC to be able to fulfill those functions and shift some of the other work to another health promotion staff person who was able to carry that. And then we had our public health analyst position that was added 3.7 years ago, and that position was eliminated as well. And the duties that were rolled up to that position from the previous directors are rolling back to them, and we will continue to work towards a quality management program and pick up some of the filling in that gap as well. And if that means that I step into some of that capacity as my previous experience in quality management and directorship can fulfill with our management team. With that, we don't anticipate any other reductions in force and staff. There are other budgetary operational expenses that will be reduced, and that is going to be continually discussed with Commission as well. It is not, it will be in public anyway on Monday, but we're looking at the reduction of the nurse family partnership program, which has been in consideration from the nurse manager, the director of the nursing department, for several years. It's been an expense to manage the license of that program. It also reduced the number of clients that the nursing staff could see. And by not having that and not having the restrictions of that program, we're actually able to see more clients with the staffing that we have working in the MCH program. So that is another program that you will see reduced, not in staff, just in the name of the program. Are there any questions on?
Any questions from board members on the budget recap?
To add to that, we also have realized more revenue from Cass Public Health. Environmental Health Grants team has looked at ways in which doing permits and licensing, matching what other cities are doing with drive-out fees and base fees to start services has been something that we'll be adding. The nursing department, looking at revenue codes that they have for services within our home health nursing, is also something that will be changed. It's a code that actually doubles the cost of the service that they're providing, and it's allowable through Medicaid, which has been reviewed, so that it will help to sustain the program.
Any questions?
Thank you for the update. Can you just talk a little bit more about plans to fill in the public health analyst position?
There were a number of duties that were assigned into the position that many of the directors had sustained previously, whether that was some of the, each one of the departments, for example, does individual quality management elements. There hasn't necessarily been a rolled up quality management plan that all departments are reporting into. As far as the population-based public health component, I did have a conversation previously with Lynn about how we should move on into the next subject as to number 5, actually. As a community, we used to have health departments work together, Sanford, Essentia, Community. You are familiar with this. That has changed within the community where now everybody is doing their own. And I would like to make a proposal that the health entities within the city work within the same community health program without having the differentiation of population base and without having to expend additional resources creating individual programs. I think we have a lot of talented people within the community. If we could come together to have one plan with all the stakeholders present, would be one of the ways I would like to propose that. We'll have to continue to work on the rest of the gap planning.
Thank you.
Okay, I just wanted to review some statements that I had considered over the last week or so. So as a member of this board, I do feel an obligation to advocate for the community and for public health, and I think that that's understandable. Transparently, I've had concerns with the workforce reduction, excuse me, and it's likely because of how I obtain the information, right? The media, et cetera. And I've received a summary from Jen and talked with her yesterday, and that helped shed light in places that I didn't have the light before. So that was helpful. I also reached out to mayors and city commissioners. I did ask for them to allow the Board of Health to review in a little bit more detail the changes before they were approved or voted on. And I was told by a city leader that it would be inappropriate for the Board of Health to weigh in on this issue. So I wanted to remind this group and those in our community what the responsibilities of the Board of Health are, and they can be found on the City of Fargo's website and within our bylaws. I'm not going to read all of them, but there's just a few that I thought were important for me to note. Obviously, being a community advocate for public health, making recommendations to the Board of City Commissioners and Cass County Commission regarding public health issues, ensuring policy and legislation is based on the most rigorous and current scientific evidence based on expert recommendation or evidence-based or promising practices, provide feedback on the public health strategic plan and provide guidance on goals and objectives and ensure alignment with the health department's mission, assist in providing feedback and identifying and prioritizing programs using data, highlighting community needs, reviewing the annual budget and fiscal reports and providing a recommendation to support or revise, and review and make recommendations regarding the public health department's policies and procedures involving significant changes. So it's certainly important to be fiscally responsible with budgets, and I appreciate all of the work that you've done. I know that it's challenging. I do hope that all city leaders were asked to have the same scrutiny line by line that public health was. As I understand it today, the cuts that came from City Commission were from public health and the DE&I, correct? No other departments. So considering that the public health is definitely an essential service, that stuck out to me, right? So that I hope that people can appreciate where my concern came from. So when we do cleanup of FTEs that have been sitting open for a couple of years, if you looked at all of the departments across the city, that could add up to a lot. So I do hope, and I will be following up with city leaders on that question because those can add up across a city like Fargo. One advantage to having an advisory board is to provide objectivity. It is challenging to remain objective as a leader responsible for cutting their budget. I've been in that situation before. How are we making decisions on facts or feelings, letting personality differences or cultural history impact those decisions? And that's why a board like ours is beneficial, because we aren't tied to the day-to-day in the department. We don't know the humans behind the work. We know on paper what needs to happen and how we get there, and can bring some objectivity to those decisions. So I hope that the leadership team at Fargo Cass Public Health can see us as that kind of partner. We are an advisory board, not a governing board. We have volunteers from the community with really great backgrounds and experiences, and would love to be able to use those to help with this. One thing that I have noted with these changes is that the city leaders have not changed. The city leaders have been responsible for the oversight of this budget for a while, and so, admittedly, I have questioned the timing with the recent change in public health director and a city commissioner. And I say that because maybe it's easier to do it when you have someone who doesn't have the history, but then again, where's that objectivity coming from the entire group? So not a slight at all to the new city commissioner or to the new public health director. That's more of a question that I have for city leadership. And then just to summarize why I had the concerns that I had, and I do, share these. I got feedback from the community. One of my biggest concerns is, how are we going to be funding public health in the future? Are we really truly wanting to reduce local funding as much as possible and become a grant-funded public health department? I don't know what standard practice or best practice is. I've tried to find that information, but what I do know about grants is they're not guaranteed and they're temporary. And our community deserves people who are committed to the work long-term. And so that is something I'd like to find out more from, not even you, but your leaders. Like, what is their expectation and what is reasonable, and what can this board do to advocate for securing local funding long-term. What other city departments rely on grant funding, and again, what is the city's goal for how we should be funded? Another thing when we switch around buckets of work is making sure that the people who are responsible for those buckets of work have the appropriate background. So whether it's nursing or immunizations or tobacco or obesity, who are the people that are going to be getting that work with these shifting of buckets to ensure that we have people with the appropriate backgrounds and expertise to do that. And then just strategic planning in general. We had attempted to become accredited within the last few years. While the department did not become accredited, we did invest a lot of money in a consultant that helped us develop a strategic plan. And so what will that look like going forward? And how will the budget support those types of things? So a lot of this is probably future discussion, and again, follow-up that I have with the city, but I just wanted to share that so people could understand where I was coming from when I reached out to city leaders with concerns.
Commissioner Kolpak also echoed your statement. Commissioner Strand did also on Monday evening, asking for other cabinet members to step forward with a review of their budgets and their staffing. Commissioner Strand did give a no vote on Monday evening to the budget and asked for them again to go back and reconsider. Commissioner Kolpak was able to say yes to that, stating that the directive had been given to all cabinet members to do that. As I understand it, there's 3 positions that are asked for further review by Commissioner Strand, and we will maybe find out more of that within Monday or also on next week, Monday. In regards to the accreditation, understanding that was not achieved. It has been a conversation within small management as to the pros, cons of doing so. I like accreditation standards. I like the quality management piece that it brings. I like the rigor that it demands. It gives us as an accredited body at some point to be able to continue to hold that high bar and maintain that for our community and constituents. So it is a conversation that we're still having. The strategic plan will be part of that. With city leadership's guidance, we'd look to redevelop that, begin that at the end of this coming year.
And I recognize my own bias about accreditation and quality because that's what I do at Sanford. So I think that I can appreciate the complexities of it. So, okay, any other questions before we move on to the next agenda item or discussion?
Yeah, hi, this is Nimal. I have a question on, can you hear me?
Yes.
Okay. I have a question on the position that are occupants at public health that are being cut. And it sounds like they've been there for a pretty long time. And there's a lot of our community been applying for those positions. And what I'm trying to understand, why are those positions are not filled instead of being, like right now, the city wanted to cut those positions. I just want to understand from your point of view as a leader of a public health in our community, why are these are not filled from the beginning before cutting them now?
That's a good question. I can address 2 of the positions. The first one is in our employee health division. A couple years ago, I think it's been about two years ago, we had an employee, a registered nurse that transferred to a different department. And at that time, we looked at the duties, responsibilities, tasks of this individual, as well as being fiscally responsible to the city. So we evaluated the pros and cons of that position. And what we came up with is we really needed more provider time. We contract with Essentia Health to provide a nurse practitioner as well as a physician assistant. So we increased some of those hours. And then the duties that require a registered nurse scope of practice, I am assuming those responsibilities and have so since. We did it initially just to try out to see if this model, this concept would work, and it did. It works very, very well. And I know we provide outstanding care for the city of Fargo employees. So to me, when Jen and I visited about that position, it just made total sense. We had enough of a time to trial this to see if it would work, and it is working. It's working quite well. So that was the reason for the one FTE in employee health. The nurse practitioner position, where we had an employee go from 1 FTE to 0.8, we were looking at our clinic numbers, and it really was a preference of this employee asking if they could go down to 0.8. So it really was a win when our numbers justified that, as well as the employee, who it's no secret, she has shared with individuals that she's, just has a few years left. So before she totally is done with the city of Fargo and the clinic, she wanted to work 4 days a week, and we accommodated that. It's been a few months now, and it's working extremely well, and our numbers justify that. So in my mind, it's just another way that we're being fiscally responsible. So those are two of the positions that I'm quite involved in, and Jen and I have had meetings about.
And Niamal, to clarify, the two of the full-time positions that were cut were vacant, but they had not been posted for a few years. So there weren't people from the community applying for that position. They had just been unfilled and unused.
Thank you. So just getting back to the public health issues of cutting job in our communities, I feel that, even though, we're not talking about the city of Fargo voting to eliminate, the DEI program, but just so as a public health and in our community, and just as you guys are, cutting the DEI program is one of the, it came as a surprise for me, let me just be honest. Because Fargo has grown a lot, to so many different backgrounds from different diversities, and then also into the public health, because you guys already know that how important it is for us to have the diversity within a healthcare system, how important it is, having those input. It's really crucial for public health, healthcare, even when you're making plan of care for somebody. So I hope that, I have talked to Commissioner Denise Kopak, and the mayor too as well, but it was a short time, that I just wanted to understand why we eliminated it. And if there's a way that we can rebrand it, because this community is, like I said, have so many people that are diverse in it, and having a diverse perspective, it really increased the care for everybody. Eliminate it all, it's not going to do any good for all of us. But I hope that, when having those decisions put in place, you have to understand why and what was the purpose. Do you have other people from the diverse background that can weigh in to your decision of cutting those? Because I understand, I heard one of the comment from the city commissioner. It was very interesting, but I'm not going to repeat it here. But overall, I just want to make sure, you guys are really putting your input in it, because at the end of the day, it's going to come back to the public health settings and public health communities, and that's not going to look good for the public, for Cass County Public Health. Cass Public. Yes, there we go. All right. Well, I think I'm done, and I just wanted to mention that. But other than that, thank you.
And I recognize that the scope of the DE&I cuts was not a Board of Health decision. I will note that while I was doing some research this week, that the American Public Health Association, two of their priorities this year has been securing local public funding and diversity, equity, and inclusion. So the decision was not within the walls of public health, but it is certainly a public health issue. So I do echo what Niamal's concerns are. Yes, Holly.
I apologize for the interruption. Brian is letting me know everyone who's speaking needs to move their microphone a little bit closer. Okay. Sound is not coming through very well, so apologies. Thank you.
No, that's okay. Thank you for letting us know.
I'm hearing a bit of an echo that's making it hard for me to hear others around the table. I don't know if anything can be done with that.
That's why I was kind of back from the microphone, so.
In response to your question regarding the percentages of grant funding and our decreased reliance on the general fund, the Fargo-Cass Public Health has a $15 million budget. 50% of that is funded through the Fargo General Fund. 8% is by Cass County, 6% is state aid, 20% is grants, and 15% is self-pay and fee-for-services. I can get you that in an email, Lynn.
Thank you. Appreciate it. And then kind of like we talked about yesterday, I'd be curious how that compares to other public health departments.
I met with the southeast regions this morning, and some of them are a third, county, state, and grants. And they were at the state conference this week and talked about the state grant dollars that our state health department is largely funded entirely on grants. And so we are looking to increase where we can a workforce that focuses on grants and having them be hired perhaps seasonally or temporarily in fulfillment of the grant scope. We just applied for a grant as we can move into the next topic, but we did a grant application that Dr. Newman actually gave to us. So it would be a partnership between NDSU and the health department on increasing immunization confidence. Would be great partnership. We hope to get it. There's only going to be 4 awarded in the country. But it's a work effort that would have involved some of our staff to be able to carry that initiative forward. And it would have involved funding for their positions, which would allow them to be drawn less on the general fund. So not necessarily to decrease our reliance on, but to help out where we can and being fiscally responsible.
And that's helpful information. I would like to see the comparison with other counties like size, because as the largest one in North Dakota, it's kind of hard to compare with other counties. But I know we'll continue to get more information, so appreciate your help with that, Jen. Anything else on the budget? Okay, we can move on to the next item, which is the grant application.
So just to touch on that again, we did complete a grant application. It was a 3-department effort between the nursing department and the clinic and also the emergency preparedness department, and all of them offering a staff or a portion of a staff's time to promote education into the community regarding immunizations that are coming out, and to help them to increase understanding about those, and also to help them to understand or gain confidence, if you will. And if so chosen, at the end of that educational opportunity, to receive an immunization from one of our immunization nurses who would have been present at the training, there was going to be there's hopefully going to be an educational opportunity multiple different times throughout the next several months as the fall respiratory winter season of immunizations are ramping up. And also education going out to medical providers to help them increase their conversations had with clients, to help them increase their own immunization confidence. And it was something that Siri from NDSU was looking at doing and then handed to Fargo-Cass Public Health, and then creating, and I'm looking at Dr. Newman because she works in the Siri program as well. But having that partnership with them and having the education that they created for us to be able to deliver to medical providers with their assistance and to our community, also creating an opportunity for us to have roundtables with community members and making sure that they're aware of the immunizations, especially those that are underserved. We will find out next week if we get awarded or not.
Okay. I know with the vaccine hesitancy that we have in our area, our state, it's a needed grant. Any questions on that grant? Okay, well, we look forward to hearing an update next week. Next item is the community health collaboration.
This is an ask. To go back to, since I've started, there's been a work on the community health improvement plan, our community health assessment plan, and looking at population data. And the first catchment of that data, as reviewed with the health analyst, has been middle income, white clientele. That is not who I see walking in the doors of Fargo Cass Public Health, to be fair. So looking at making sure we have a good population catchment, but also wanting to make sure that we're having a health plan, a health assessment plan that is consistent with other facilities in our city. We have the same community, and many times we're serving the same clientele at different levels. There was a time, if we go back 15, maybe even 10 years ago, that the stakeholders came together to have a plan, and people maybe would do different things between Sanford or Essentia, but ultimately our community catchment was the same. Our needs within the community are the same. How each one of us approaches those needs and applying our efforts towards those are different, but our community is one. And so bringing our resources together, we can share that. We can share our expertise with public health into Sanford, into Essentia, and with your expertise into public health, and having that be something that comes back together. So this is an ask for us, and for even I'll include family health care into the conversation as the folks who are doing the community care. And so I don't know the best way to step forward with that, but it is a proposal I'd like to come to the table with our Board of Health to help with an opportunity of creating that once again in the community.
I know that the need for data sharing has been there for different things. Public health has grants that they could benefit from more data than you're able to collect from your population. And healthcare organizations collect a lot of data. So I think there's opportunity there to come together. And you and I have discussed it a little bit, and I think it's definitely a need. So I fully support. Again, I'm not sure exactly what an approach looks like, but I don't know if anyone else has questions or thoughts.
I think it's a great idea. There was sharing that happened in the past and did result in some good collaboration, and it's always great to have everyone on the same page. Like you said, our interventions aren't going to be the same with all the partners, but so that everyone's aware of what everyone else is doing. That sounds like a great opportunity, so I encourage you to move forward with that.
Same, I'm in agreement with that.
Well, maybe you and I can put our heads together and come up with a way to, engage stakeholders and even start with a meeting and see where it goes from there.
This will be one of the critical arms for our strategic planning moving forward.
Sounds good. Yes, thank you. Okay, next item is Fargo Cass Public Health Board of Health collaboration.
I wouldn't say it's an exact debacle as to the communication that has happened so far, but maybe close. Being new to this position, I don't know if I've had missteps or not, moving into discussions with commission and following city leadership, and then to respect to the Board of Health, where the direction comes from. I also am aware of a history of this board, a little bit, of how people have presented or attended. And there used to be more of the management team present historically, which has changed over time. And in our small management group, there was discussion over our managers not knowing our board. And so I would like to move forward with our management team being present. Either I like this forum of having conversation and for us to work with the board. I've seen other boards and other work groups in this room in chambers do this, and I like how things get accomplished at the end of those meetings versus the formalities. This is, to me, a working partnership. And I would like to move forward in ways, but I need to understand further how best to do that. And so if I could learn from you in this process of that, and if there are things and expectations that we can start to kind of move forward with, and if that happens in a conversation right now, or if those are for things to follow, and understanding the time that we're at, but how do management and the Board of Health move forward, and how do we call upon our board members for the expertise? And Larry had a grant or something that was being signed off, and that person's on our board, and we was not aware the person's on our board. So I want for you to know our management team and the expertise they deliver in their departments, and for us to know the expertise that our board members come with as well.
I appreciate that. Just any thoughts or discussion from the board?
No, I think it's important to know in the departments what's going on and to have everybody on the same page and communication open. Because if it's not brought to us, sometimes we don't know. So I think that seems like a really good idea.
And again, I think what we can bring is advocacy for what you need. And if we don't know what you need or you're trying to do that by yourselves, I hope that that's what we can bring. So.
Thank you. We can etch this out as we move forward.
Yeah, I agree.
Thank you.
Okay, next on our agenda, we have a presentation on the North Dakota Hepatitis C Elimination Council. And welcoming Amber Slevin, is that correct? Okay, yes.
Thanks. Hi, everyone. I'm Amber Slevin. I see some familiar faces. I am a clinical pharmacist by trade and currently serve as the chair for the North Dakota Hepatitis Elimination Council. And so Kayla invited me to give an update on some of the council's work, most notably our elimination plan and some updates that we have on data and progress. And so these are our objectives. I'll summarize some current hepatitis C data that we just recently had finalized, and then we'll briefly discuss the Elimination Council's work, our current plan goals, and I'm going to highlight just a couple of areas of progress as well as some opportunities that we're hoping to make more progress on than we have been. So this is our updated data of confirmed chronic hepatitis C case counts in North Dakota. We are seeing somewhat of a downward trend. I will note in this that it is currently not well known how adherent, I guess, in general, the North Dakota, primary care preventative health are to universal hepatitis C screening. So every adult should be screened for hepatitis C at least once in their life. Screening should happen during every pregnancy. And then for those with ongoing risk exposures, screening should be done regularly. And there are practices with that would suggest about every year or two. And so this is the data that we have from those that were screened. We know also that the population that is acquiring hepatitis C is not always strongly engaged in primary care and preventative health. So also, you'll see in some of our goals that we're looking to co-locate more of these services with other syndemic type services. Our surveillance team at Health and Human Services has put together a hepatitis C clearance cascade. So every step from that initial screening for a positive hep C antibody to the follow-up RNA testing that should be done, and then how many positives have been found, as well as how many of those cases have been cured. We do have the opportunity to cure hepatitis C in an individual with medications that are safe and tolerable and over 95% effective, really close to 98, 99% in most of our patients, as well as those who have very few that have either had a reinfection or failed treatment. And so the clearance cascade for hepatitis C, this looks a little bit different than some other studies just in how they follow the CDC's case definitions, but you'll see really pretty common trends in even different ways that this data has been gathered and analyzed, in that there's a really big gap between those who have hepatitis C and those who have been cured. And so there's a lot of different things in that process of diagnostics, linkage to care, treatment, verifying cure, and then prevention really bookending both of those, prevention after cure as well as before getting infected in the first place. So this is over the last 4 years, and then the 2023 specific data I included as well. And lastly, for the data that I have from our most recent analysis is our case counts by race. So you'll see that we're seeing pretty significant decreases in case counts diagnosed among white individuals, and the decrease is somewhat smaller among Indigenous. And so you'll see in 2023, for the first time, those case counts were actually equal. There is some discussion on perhaps that screening is actually stronger in some of our IHS sites that have done incredible work with hepatitis C, but I also think that the disparity is pretty undeniable. Any questions on that data before I move on to the council?
I would just note that the disparity that you see is linked to DE&I and how we approach our work. So again, that lens is applicable in public health.
This seems to be a gross undercount of cases. Hepatitis C is the most common bloodborne infection with an average prevalence of about 1% of the population. And by that means we should have around 7,000 cases in the state. And even the highest number I see in 2019 is only about, can you go back one slide, please?
For this one or back?
That one.
Yep, so these are the new confirmed cases per year, not the total cases.
Okay.
So this
are
would
the
be
total
over the
cases.
last 4 years, the amount of RNA positive.
Okay, thank you.
I still think that it's certainly underdetected, underdiagnosed, and we are seeing even some lack of follow-up with those who have an antibody positive and having that RNA confirmation after. So there are several steps in access to diagnostics, complete diagnostics, linkage to care and treatment, where a lot of folks are missed. So I would still agree that it's certainly under.
Yeah, that's a well-known problem, and how we have tried to overcome that problem is at the point of care when we have done Hep C testing, the positive antibody test automatically reflexes to RNA, and I don't see a reason why that should not be a standard of care.
There's only one health system that I'm aware of in North Dakota that doesn't do that. Every other health system does. There are a lot of CTR sites that only have point of care availability with the hepatitis C antibody test. And so they refer for folks to have RNA follow-up. That doesn't always happen. There was recently approved a hepatitis C RNA point of care test that could help. There are some downsides to it right now, but it is something that I think that HHS would be pretty interested in knowing about, those who are doing high volume outreach and the ability to confirm. But that would be one of the gaps, in a clinic setting. We're seeing reflex as the standard. In other outreach type settings, that's not feasible right now.
Thank you.
Okay, so background just briefly on Hep C elimination. I'm sure many of you are pretty familiar with this, but because of our curative agents and effective practices for preventing hepatitis C, elimination of the virus is feasible, is possible. The World Health Organization has goals to eliminate by 2030, and really their some of the landmark goals is to reduce new infections by 90% and reduce Hep C related deaths by 65%. But this does really require an all hands on deck approach. This isn't particularly with our current population just going to be happening only in a primary care doctor's office, and although certainly not, certainly very important players in the game. But everything from education, prevention, really rigorous screening, helpful linkage to care, and then ultimately hepatitis C treatment access and support while on treatment. The North Dakota Hepatitis Elimination Council was formed in 2022 and is made up of a variety of folks, clinicians, public health, SUD, substance use disorder, behavioral health, syringe service program folks. We have a representative from the Department of Corrections, and our first charge by HHS was to create a 5-year hepatitis C elimination plan specific to the state. And so the two things that we really used as our roadmap for creating that were national guidance documents, guidance for jurisdictional planning, and as well as the national plan. And we sorted out our council by specialties and areas of work, so community-based interventions, clinician services, and our data and surveillance folks. Our goals really align with the national strategic plan. It's the strategies beneath these that are really tailored to our population. And so preventing new infections, improving outcomes for those who already have the infection, reducing disparities and health inequities, improving viral hepatitis surveillance and data usage, and then integrating efforts really within this endemic. If anyone wants to look at the plan, I would be honored for you to read through the whole thing. I don't think it's on the top of many people's weekend reading list, but we're excited for the work that has been done to create this, and it's been a really helpful guide for us. And so this is the link to the plan, and I wanted to just highlight a couple of areas. There are multiple strategies per goal and multiple key performance indicators per strategy. I wanted to highlight just a couple that we've made progress on, and a couple that we'd really like to see some more movement on. So one of our big goals was to increase the number of providers who treat hepatitis C in the state of North Dakota, especially in some of our rural areas where specialist access can be more difficult and not necessary for a lot of the new cases that we're seeing, as well as locations and services for substance use disorder. And then leverage the role of nurses and pharmacists in areas where they may be able to, catalyze some of the efforts in treating. And so in the last 1.5 years, we've trained 10 new healthcare professionals that are currently practicing. Hepatitis C treatment services have been established at Share House and other substance use disorder facilities like Community Medical Services. Ideal Options just last month started treating as well, and these are really, really key locations and services for a good chunk of our population that isn't engaged in regular care. And then we're working on as well forming some partnerships with residency programs to further integrate Hep C treatment into general practitioner training. So we've had 6 family medicine residents trained so far in 2024. And so this is part of what we'd like to do. We have big portions of the state where no one is treating, and really trying to target those areas and find folks that would be interested in providing that service for their community. It has been traditionally a specialist area of treatment, and there are still cases that require that, but the large majority can be really effectively and safely managed by a general provider in a general clinic setting. Identifying and minimizing costs and insurance-related barriers to viral hepatitis care and treatment. This has been a really big barrier to treatment, is just really extensive and not evidence-based barriers to having insurance coverage of treatment. The hepatitis C treatments are expensive. We started out this strategy, I would say, with a really effective collaboration with North Dakota Medicaid to eliminate quite a few different administrative as well as patient criteria that had created barriers. As one who used to do the prior auths, I would be Friday at 5 p.m. at the fax machine with one prior auth packet that was about 40 pages thick, and then didn't go through. And so things like that have changed, for the people who actually have to do that work. But also things for the patient. There used to be sobriety criteria that not only was, someone's report of their sobriety journey, but also like needing to confirm with labs that was really the case. And so one of the several changes that has been made is creating a harm reduction pathway to hepatitis C treatment access, so that no matter where someone is in their substance use disorder journey, there is a pathway to hepatitis C treatment coverage. We are hoping, this is more of an area of opportunity and hoping to identify opportunities to collaborate with some commercial payers as well. Some of our commercial payers have really pretty extensive and even somewhat outdated criteria for hepatitis C treatment coverage. One of the other things that we had aimed to do and is now done, but we are looking to increase knowledge of, is create a director of those providers in the state that do offer hepatitis C treatment. So we've been working a lot with folks that aren't necessarily within a clinic, but that are in a position where they may be able to help connect persons living with hepatitis. And so there is now a directory of providers in the state that treat, and with the goal of increasing the efficiency of linkage to care, and for us to also be more strategic in who we're reaching out to offer training and support in getting treatment services started. And one of these was the peer support counselors for those in North Dakota with substance use disorder, and in just navigating the entire Hep C care cascade. And so that we gave a webinar on hepatitis C treatment, some of the big changes in access, as well as some of the new tools that we have to link to care twice this summer to that network, as well as those in the behavioral health network. Next, utilizing our care cascade surveillance strategies to re-engage patients who are in need of hepatitis C. So the surveillance department within HHS is already in the process of, reaching out to individuals to gain data. And so leveraging those phone calls and those contacts to also link to care and educate has been a big win over the last couple of months, as well as their interactions with the providers who are screening and helping them to either pursue the knowledge and skills needed to treat their patients, or help in creating a more seamless access to care process. one of the big areas nationwide of focus with hepatitis C screening and treatment is in correctional facilities. And so you may be already aware, but the North Dakota Department of Corrections has done incredible work in the prison system. They have 100% opt-out screening. Not so long ago, they had worked up to in their budget to being able to treat about 30% of folks in correctional facilities who have hepatitis C, and just within the last 2 years, they've gotten that number to over 50%, and they're on track with quite a few different strategies that they've employed to being able to treat almost everyone in the prison that test positive for hepatitis C. So that has been really incredible work in our state and has a really big impact on our population, given the number of folks who have hepatitis C who go through the correction system. We have significant barriers that remain in jail setting. We could get into that another time, but we have a short-term goal of just trying to move the needle on screening and linkage to care with a more long-term goal of care integration. But there's a lot more that I can't represent probably in one slide on our barriers there. Another opportunity that the council is aiming to focus on over the next year or two is measuring and increasing hepatitis C screening rates during pregnancy, including linkage to care for treatment after pregnancy, and potentially as safety of hepatitis C treatment during pregnancy continues to be studied, perhaps also during pregnancy at some point down the line. And so that is an area that hoping to see some efforts and movement on. Another is scaling up implementation of universal screening guidelines. As I mentioned in the beginning when I was presenting the cases, we really don't have a great denominator of how many folks have been tested for hepatitis C and have been negative. Only the positives are reported. And so there's still, we believe, a pretty big difference from health system to health system, provider to provider on implementation of screening guidelines, as well as continuing to form partnerships in more key locations in offering universal screening, which again, in a lot of those cases gets us into the position where we're testing for the antibody and don't have RNA, but not necessarily always. And then again, co-locating our services as well, as I've mentioned throughout. These are a few references. I'd be happy to answer any questions.
Thank you, and congratulations on a job well done. I know this has been a very long and painful journey, and quite shameful in some sense that, despite availability of antivirals that are very well tolerated and offer 95% cure rates, we are still talking about this 10 years down the line. And I think we need to focus our advocacy efforts and make sure that things like this never happen again. Where for a straightforward medication, we are filling out 40 pages of prior authorization and implementing rules where so there are certain sobriety criteria. All that has done is exacerbate the health disparities even more. So I know you have personally been fighting this battle for a long time, so I just wanted to congratulate on all your hard work. Good job.
Thank you, and thanks for your support at many points along the way. I appreciate it.
I just want to echo that as a treating hepatitis C provider. The amount of progress we've made has been really huge. We still have a ways to go, and sometimes I occasionally still have to get Dr. Nagpal's stamp of approval before a script will be approved by insurance, and I just really appreciate your collaboration with that and your help and allowing me to continue to
treat people with Hep C as well.
Do we have universal screening process at Fargo Cass Public Health?
Yes, currently we do screen for both HIV and hepatitis C. We do initially, for most cases, a rapid test, and then we do and are able to do the confirmatory for individuals who utilize our clinic service. Over the last, I'm going to say, year, we've been doing more of an effort with our outreach services. We go to a variety of different places. We go to syringe services. We go to residential treatment facilities, shelters, the Cass County Jail, and provide testing. I don't know if Amber remembers this, but Amber and I and a few of our team met a few years ago, and she was extremely helpful with meeting with our staff, providing education and guidance, and where we can refer individuals who do test positive. So we do test a number of individuals, and the education and guidance that we received from Amber was extremely valuable for our clients and our community.
Of course, I remember. You guys do great work.
And then just one thought that I had as you were talking about some of the barriers that you've maybe experienced, like with commercial payers in North Dakota. During COVID, the board would provide letters of support towards different things. And so that could be something that we could consider during that process. If you find that a letter of support from the Board of Health would be beneficial with talking with commercial payers, I think you can let us know and we can talk about that as a group.
Absolutely. Thank you for that offer. I appreciate that. Also, if anyone is connected with folks on the western side of the state, we're also in a pretty big need out there for treating providers. So a lot of that, we've tried just different newsletters and things to recruit. We offer training for free, and I try to make it really efficient for them. And so, but it is often the one-on-one connections that yield our best results. So just personally, if you have connections.
I'm just curious what the bigger barriers are for universal screening in the county jail system is. I know we're not universally screening our inmates at Cass County currently. So I'm just curious if you know, I assume cost potentially being one of the bigger barriers.
So I have been told a few things, and I'll say that this information is secondhand. So I think that more conversations could be had, but some of what I have heard, and I've only been in direct collaboration with a couple of jails, and they actually are screening with the state-funded CTR. And again, that only funds right now for the antibody testing. And so some of our jails that are part of CTR can screen and offer that free to individuals. Others that aren't a part of that or don't have that, it would be cost. The other thing that I have heard is that it does put them in a bit of a pickle, to use a very formal term, that they're diagnosing someone with a condition and concerned about the liability on then following up with that, which they don't have the resources to do. And so that is particularly one that I have heard. The other thing too is if there is a positive antibody that requires the follow-up RNA testing, that often becomes the individual's then financial responsibility, and they like, for example, those who have Medicaid who go to jail do not while they're in jail have active Medicaid. So then that is cost to them. There is a reduced rate through the state. It can be done for about $30, but it's declined and not infrequently. And so those are just a couple of things. So right now, one of the things, Kayla, if you don't mind me sharing, that we're looking to do to improve is start some telehealth services that would allow for individuals in jail with a diagnosis to be connected with a provider that could then treat afterward, either in person or via telehealth, so that there is more of a provider-patient relationship established in that setting, the opportunity for education and linkage to care. Now that's going to be most impactful in our jails that are screening and confirming cases. So many jails are not screening, and so those opportunities are, seeking like CTR from the state. But I think I would have to understand better what some of their barriers are, even with that opportunity. It's not always taken.
Touching on the same topic, in your opinion, what is the biggest barrier that you face enrolling more providers in the for hepatitis C treatment? Seems something fairly easy that most people should be feeling comfortable doing that. What do you think is the barrier that's preventing? I understand, there are certain requirements from the insurance companies that only a specialist can treat hepatitis C, which, again, I don't agree with. But we have had issues recruiting primary care providers, getting them interested in treating hepatitis C. But in your opinion, since you have been dealing with this and working on this for a number of years, what do you think are the biggest barriers among providers willing to take Hep C treatment?
Mm-hmm. I would love for Jamie to do a study on that. I think that you would probably design a good study, because I wish I could understand it better. I don't understand. I don't know if it is that it's intimidating with the fact that hepatitis C treatment used to be pretty complicated, and if that's a norm that has been perpetuated despite the changes in treatment and simplicity. Even 8 years ago, when we did have very effective therapies, it was like different by genotype, and resistance testing was needed, and some people were still on a medication called ribavirin that had a lot of side effects. So I think that there have been, those who just weren't trained in the more simple, the simplified treatment pathways that we have now with all of our agents, have continued down that path. I think that a lot of particularly primary care providers are really strapped for time. They're seeing a crazy amount of patients every day. So to not only stop to learn a new skill set, but then to offer a new service could perhaps feel not feasible. And then I don't know, I guess I would be curious too what support there is from health systems who have just always had the practice, bigger health systems, of referring to a hepatologist or infectious disease specialist, and that's just always been the norm. If there is more reasoning behind that versus just the way we've always done it.
Yeah, so as a primary care provider, I think, interest, time, especially in the big healthcare systems. So in these large corporate healthcare systems, it's all numbers based and how many people you get through the door. And so it's one more thing to add to your plate. And so there is a little bit of a learning curve that comes with treating. And so I think in talking with others, and I do have the family medicine residents with me at Share House, and I'm trying to train them. It's just, I think they're feeling also pushback from administrators on, no, you need to refer that out. So, but I think the biggest barrier is time and how many patients people are required to see in a day.
And our hope would be to, and Kayla's partnered on this, to really change that norm from the level of entering into practice, that from day one in someone's new practice, that's just a normal thing that you manage in primary care if there aren't significant complications or co-infections. I think, just starting at at the root of it there, we'll hopefully see some change in the norm.
How many of the residency programs are participating?
Right now, we've done training for one, and we have intentions of getting connected with a few others. I have a meeting next week to hopefully get connected with a few others. So the curriculum is developed. You've already developed it. It's more about getting on their didactic agenda.
Okay, any other questions or discussion? This was really helpful, so appreciate you, Amber, for coming, and thank you, Kayla, for recommending this topic.
Yeah. Thank you so much for having me.
Thank you. Okay, next up on the agenda is Health Officer Update. Okay, sounds good. Okay, good afternoon, members of the board. Thank you for having me. I'm going to present my report today is intended to kind of update you on some respiratory viruses that we follow and survey in public health, review and update you on some of our vaccinations that are available now, and then I'll end by giving you a pertussis update as well. So as usual, just stop me with any questions or comments or the like, or I'm happy to take those at the end as well. So we'll start with influenza, one that's very known to us. This is just kind of to show you the burden of influenza in the United States every year. This was data obtained from the year 2010 to 2023, and it's showing you on average per year what influenza looks like. So starting at the bottom, it's anywhere from over 9 million to upwards of 41 million outpatient visits or illnesses each year. We bring in, on average, 100,000 to over 700,000 people into the hospital each year in this country, and then we average from around 5,000 to over 50,000 deaths. So influenza is one of those very variable illnesses. It can vary widely on a number of factors, including the circulating strain of virus that year, how well matched our vaccine is to that virus, the season timing of the season, and then actually how many people get the vaccine. So that's accounting for the wide variation that you see there. So this season, the 2024-25 flu season, we have a vaccine that will cover 3 strains of the virus. There are 4 products on the market. So flu virus mutates really rapidly every season, as you guys know. We kind of have to do an educated guess in healthcare of when we make our vaccines. Fortunately, it looks like we have a good match this season. We look to countries in the Southern Hemisphere who experienced the flu season before the United States. And when you look at data coming out of Australia, for example, in their flu season, the flu vaccine seems to be an excellent match this year. So optimism for that. Last year, the flu vaccine reduced the risk of an outpatient medical visit by anywhere from 40 to 60%. So it is recommended that everyone 6 months and older receive an annual flu vaccine. Protection wanes throughout the season, as we know. So October is often said as an ideal timing, although that may vary depending on your personal risk. So talk to your provider, of course. But in general, we say boo to the flu. We'll say that again this year. And Fargo-Cass Public Health has flu vaccines currently available. So. And in fact, we are hosting some Flu Shot Fridays this season. So on October 18th and October 25th, various times we'll be offering those in our Oak Room at our main building. We will have vaccines available for everyone who's eligible on a walk-in basis. We also have the high dose vaccination for our older folks, 65 and above, and COVID-19 vaccines will be available upon request. Switching a little bit to RSV, also a burdensome illness in the United States for our kiddos under 5.
We usually experience over 2 million outpatient visits, upwards of 80,000 hospitalizations, and anywhere from 100 to 300 deaths each year. For our older people, 65 and up, we experience anywhere from 60 to 160,000 hospitalizations and anywhere from 6,000 to 10,000 deaths in the United States. RSV is one of our very common viruses. It is very well known to us in the pediatric field. Most children by the age of by the age of 1 have been infected, and nearly everyone by the age of 2 years has come into contact with this virus. RSV is indeed the most common cause of hospitalization for our infants in the United States. And we know things like prematurity or being born early or having an underlying chronic disease does increase your risk. But what's interesting about RSV is that the majority of people who come into the hospital, almost 80%, are healthy term infants who have no underlying issues. And this is just data from the CDC pointing out that your risk of hospitalization is higher the younger that you are. And so we do have products available this year, or this season again. Nirsevimab is our monoclonal antibody that is intended to protect young infants against RSV. This will be the second season that this is available. So it's not technically a vaccine, however, it's treated and handled and presents a lot like a vaccine. A monoclonal antibody is more of a passive form of immunization. So we get active immunization when we either have an infection or receive a vaccine. We get passive when you somehow receive already formed antibodies and that's given to you. So either like transplacentally from mom to baby, breastfeeding, sometimes when we give IVIG for things, and then this is another example of that. But it worked very, very well last season. Some studies said 98% of efficacy rates, but anywhere from 80 to 96% reduction of risk of hospitalization. So what's great about Nirsevimab is that all infants are able to get this under the age of 8 months if they are either entering or in their very first RSV season. And then a certain subset of high-risk older toddlers, 8 to up to 19 months, can also receive this. And I would point out for our area that includes American Indian children. And we think this protection lasts anywhere from 4 to 6 months. So last year we had some supply issues with receiving this, that those are not anticipated for this season. And Fargo-Cass Public Health does administer this. We have only the 5.0 milligram dosing for infants. We also now have a product for pregnancy to help prevent RSV. Abrysvo is the first FDA-approved vaccine for pregnant people. This really helps prevent RSV in our infants aged 0 to 6 months when we know they are the highest risk of coming into the hospital and experiencing severe disease. Fortunately, thousands of pregnant women got this last year, the first season it was available, but this has really given us the ability to confirm the safety and high effectiveness of this vaccination, anywhere of 70 to 85%. And we saw higher efficacy the sooner, the younger in babies, so age birth to 3 months, efficacy rates of around 82%. When you follow out to 6 months, it was around 69% for preventing hospitalizations due to RSV. This vaccine is given seasonally, so typically September through January, and we give it at a particular time during gestation between 32 to 36 weeks. This vaccine can be given simultaneously with the other vaccines we routinely give during pregnancy, so things like Tdap and COVID and flu. And this is one vaccine that Fargo-Cass Public Health does not administer. We do, however, give RSV for our older adults. So this season, there are 3 RSV vaccinations for our older adults. There are pros and cons to each one. This is not an annual vaccine for this population. So if someone in an older age group got one last year, they do not need one this year. Studies showed that receiving a second vaccine didn't meaningfully enhance protection. ACIP has said that people 60 years and older may get this vaccine, so it's sort of that shared clinical decision-making model. If over 75 should receive this vaccine. So RSV vaccines do show some initial waning of immunity after the first week, but then they seem to stabilize at very high levels of protection, actually out to greater than a year. And so Fargo-Cass Public Health does have these vaccines available for this population. And switching to COVID, wouldn't be a complete presentation. You guys are used to me talking to you about that. But as of June 1st of this year, nearly 1.2 million people have died of COVID in the United States. This is a disease, as we all know, it's caused by SARS-CoV-2 virus. Depending on the variant and the season, we know this virus can be very contagious and spread quickly. So it is the most, or it most often causes respiratory symptoms, so things like the cold and the flu, maybe pneumonia. In children, that can really vary. You can get GI symptoms and really all over the board. For the majority of people, you'll see a mild presentation. However, in some groups, we see very severe presentations of this and needing to come into the hospital and even resulting in death. And even people who maybe experience a mild disease early on can go on to have these post-COVID symptoms or things like long COVID. So COVID-19 spreads via respiratory droplets and very small particles that contain the virus. Anyone infected with COVID-19 can spread this, even if they don't know they have it or even if they don't have symptoms. So constant mutations of this has also led to us to try to need to play catch up with our vaccines and need to have newer technology. So the 2024-25 vaccines we have available have been updated. They all have new formulas that are targeting what are the current circulating variants. They either target what's called JN1 subvariant or KP2, both are which considered Omicron subvariants. Everyone over the age of 6 months is recommended to get a COVID vaccine this fall. If you were recently infected, this is a question that comes up sometimes, you are encouraged to wait 4 to 6 months to get a vaccine. It doesn't hurt if you get it closer, like 2 to 3 months after infection. Some research has shown that even waiting 8 to 12 months out will allow antibodies the ability to update and work more effectively. If you've not been recently affected, timing can be a little tricky. Our country and our area is currently in a wave right now that's sort of stabilized and coming down. But so the question may be, do you get it now or do you wait till October or November to protect the anticipated spring wave that we will almost certainly experience again? As always, probably best to ask your healthcare provider on that, knowing your unique health conditions. There is currently no flu COVID combo vaccine available, although I wanted to point out there are some in trials, in later state of trials, and maybe even available on the market by next season, which could be potentially a game changer for us in public health. And FargoCast Public Health should have our COVID vaccines by the end of this month, end of September. And just a PSA, if you will, that the U.S. government is going to be offering free COVID tests again. It's 4 free tests per household. These are the COVID antigen tests again. So people should be able to order these starting at the end of this month, late September. I did include the link at the bottom of the slide. I checked as of yesterday, they're still not available, but hopefully in the coming weeks. And there are actually now combined flu and COVID tests that are available, home test as well. Those are for purchase, however, in the market. But these can be free. And we do not yet have RSV home tests. So this is just a lovely summary slide. I'm sure Dr. Avish, you're familiar with this, put out by your local epidemiologist. I love this. It's great. It's everything we just talked about. She puts these out for free. She has printable PDFs that if you find that useful to print and hang in your office or anywhere else, please do. And then just a brief update on our pertussis outbreak. So as many of you are aware, it's not unique to North Dakota. Many places in the United States are experiencing uptick, but we are in Cass County for sure experiencing an uptick. Since January of this year, we've had 41 cases here in Cass County, and since August 1st, we've actually seen 15 of those, with 1 requiring hospitalization. So in the spring, we saw a lot of these in our adolescent population. We had a little bit of a lull over the summer, but what's interesting is now with kids returning into childcare settings and schools, primarily we're seeing this impact in younger children under the age of 5. So unfortunately, this is one of our illnesses that if you've had a previous infection or even been vaccinated, we know your immunity can wane. So that comes along every 5 to 10 years, really stressing the importance of people being up to date on the vaccine for this. So who should receive a Tdap vaccine or a DTaP vaccine? Our children, of course, under the age of 5, get a 5-dose series before starting kindergarten. Our adolescents get 2 boosters at that middle school and then 16-year age range. Pregnant women are really strongly encouraged to get a Tdap vaccine during each pregnancy, preferably in the 2nd or 3rd trimester. And then every adult should, if you have never had one, please get a Tdap vaccine and then get a booster every 10 years. And then I'll just end by saying I think the news release went out this morning. I'm looking at Holly. We are partnering, we're doing what's called a fall respiratory season kickoff. We have partnered with everyone here on the screen, North Dakota Health and Human Services, Fargo Cass ourselves, Sanford, Essentia, Family Healthcare, multiple entities at NDSU, and the Foundation for a Healthy North Dakota. But we are holding a press conference at Fargo Cass Public Health this coming Monday at 10:30. That will be in our Oak Room. And we hope to just provide the community with an update. There'll be 3 providers. Actually, Dr. Nagpal is one of them, and myself, and a provider from Essentia, just kind of reviewing the importance of the fall respiratory season and products we have available and the importance of our community getting those. We're going to have a family tell a story that how they were affected with one of these illnesses. And I guess we're having a celebrity of sorts vaccination who will receive their vaccine on camera. So if that's of interest to you, please join us for that. No, it will not be Dr. Nagpal. Can I answer any questions?
Any interest in doing any kind of vaccine blitz among our long-term care facilities in the area? Seems like that's that we might get the best bang for the buck.
I can tell you that our nurses and our staff are doing flu clinics all over Cass County, starting in October here, the first week, all the way through October, Tuesday, Wednesdays, and Fridays. So they have a schedule. They're going to some of the long-term care facilities, but also some of the, in different areas out in the county, they go to the senior centers. So there's a big schedule.
Yeah. I was specifically wondering about RSV vaccine, though. I mean, I don't expect you guys to show up at every nursing home and inoculate everybody, but if there's any opportunity to engage our local long-term care facilities and see if there would be interest in doing RSV updates.
I'm just wondering on like the Tdap and especially adults on, the 10-year guidance, and I've kind of been trying to help myself in practice gauge like with this pertussis outbreak, if I should vaccinate people sooner, because I assume the pertussis portion of the vaccination must wane prior to 10 years. It's like the tetanus part of it, technically, that has the 10-year, I assume. But is there any evidence on longevity of the pertussis portion?
That has always been a concern since we went to the acellular vaccine from the whole cell vaccine, but whether there's any benefit in, doing it sooner. I haven't heard any rumors of that yet. My guess is that studies are lacking. And I can't speak to what we have in store for newer pertussis vaccines or more potent pertussis vaccines, but I think that's an area of clear need, and I think people are working on that and just not up to date with the data.
Yeah, I would agree with that. Certainly the efficacy data of the pertussis portion is the strongest the first year after you get it. I believe it's like 80% or above efficacy, and then it wanes each year. But yes, I don't believe we have trials proving the cost benefit or whatever of that. And so you would be doing that off-label
Right.
in an outbreak situation.
Well, in the community then, if you have someone coming in that's had an exposure, let's say they're 5 years from last Tdap, I'm just always trying to gauge.
I do know that we reformulated our pertussis vaccines long ago, I guess, due to concerns about side effects and things. But now I believe that we're re-looking at that to see if we can redo them. Again, I'm not an expert on that, but.
Is Tdap required in schools? Is that a required vaccination?
Yes, every kid has to have it by kindergarten, and then in North Dakota, every child by the age of 11, I believe, or 12, has to have the booster.
And then how about licensed childcare centers?
Yes, if they're licensed. However, that may not be enforced if they're private or not monitored by the state or things like that. And in fact, we have an ongoing outbreak in one of our daycare centers right now as a source. Mm-hmm.
And I know you've been helping the Sanford and Essentia with the prescriptions for family for prophylactics. So thank you for the work that you've been doing over the last few weeks and longer on that.
Happy to help.
Okay, any other questions on Dr. Newman's update? And do we have anyone for public comment? No one signed up. Okay, thank you. Our next meeting is December 6th. Any other items to discuss before we adjourn? Okay, thank you all, and looking forward to what's to come.